A very warm welcome and very good evening to respected faculties and delegates who are attending this today's ninth webinar of ISPAN Mumbai branch on a very important topic, Nutritherapeutics in Critical Care Hepatology. ISPAN Mumbai branch takes pride in conducting academics. Kindly attend this very important and informative webinar till the end so that we can have a fruitful discussion. And if you have any queries, kindly ask in the chat box. Today, I am inviting Dr. Chandrima Pramanik, who is the organizer of this webinar. She is presently working as an associate consultant in the Sir H.N. Reliance Hospital, Mumbai. Over to you, Dr. Chandrima.
Chandrima, your
Mic is mute.
mute.
A very good evening to everyone. I would like to thank ISPAN Central and also ISPAN Mumbai for actually allowing us to organize this webinar. So in this webinar, I'm going to, sir, actually there is an echo happening, sir.
You must be sitting with a couple of other people who are also parallelly logged in. So ask anyone to log off, and you be the only person who is logged in that room.
Good evening, everyone. I would like to thank the ISPAN Central and also ISPAN Mumbai for allowing me to organize this webinar. But I would like to also say that the only person who actually conceptualized the entire webinar was Dr. Arindam Kaur. He is currently serving as the additional director of Sir H.N. Reliance Hospital. He is my mentor, and also he is the general secretary of. He has served as the general secretary of ISCCM and currently the college secretary of ISCCM Mumbai. He has multiple publications to his credit, along with organizing several webinars and conferences, and a wonderful speaker, a wonderful person, a friend of everyone in our hospital. And we are definitely very, very proud of him. And we would like to bring him in ISPAN as the moderator of many sessions, including this one. So over to you, Arindam sir.
Okay, so too generous, right? So people will think that we have a bong connection playing over here. Okay, Jairam is laughing on that part, right? Okay, so I try to, as I said that in the beginning, that we will stick to the time. So straight we will go towards today's plan. We have what we call the Nutritherapeutics in critical care hepatology, which should encompass all our patients, be it in a fulminant hepatic failure, ACLD, decompensated CLD, prospective transplant candidate, post-transplant patients. So we have the overall plan is to have a initial lecture or a didactic lecture, and then we will follow it up with a panel discussion where we can ask many questions, which can be direct, which can be good, sometimes bad, sometimes provocative, and others. And I want it to be, as it's very difficult to have a interactive proper session in an online format, because we do not know how the people are taking interest into it. So I would request during the panel discussion, please ask questions, anyone and everyone. It's your fundamental right to ask questions. So you can raise your hands, you can put it in the chat box, and as a moderator, my role would be to assimilate certain questions. I would to have a good flow of the questions. I do have a set of uh, questions in that particular order to carry forward the discussion in a proper way. I would have certain questions, but it's my duty as a moderator to incorporate your questions which are relevant. At times, certain questions can match with whatever I do have to ask. So I will acknowledge that this is a question asked by maybe Dr. Jairam or Dr. Sanjeet or anyone who is on NA will ask questions on that. So first, let me introduce Dr. Jitendra Chaudhary, who is our speaker, and then once we finish the didactic part, then I will introduce and invite the panelist over here for the panel discussion. So over to you, Dr. Jitendra Chaudhary, who is a senior consultant in our Department of Critical Care Medicine, Sir H.N. Reliance Foundation Hospital. And Dr. Jitendra is also the lead consultant in taking care of critical care hepatology or the liver IC. He has got good amount of almost 15 years of experience in critical care, and he is a very nice, decent person with a perfect blend of proper attitude and good knowledge in critical care. So let's listen from Jitendra, and then we will go for the panel discussion.
Thank you, Arindam sir. And I would like to thank Dr. Sanjeet also to invite me to be part of this session. So I think let's just start with our initial part. So I will be just speaking few words about the nutrition in chronic liver diseases. So liver is the one of the most important organ in the body which serves variety of functions, including metabolic, vascular, secretory, detoxification, storage functions, excretory functions. Out of which we will be focusing our focus today is about the synthetic and metabolic functions. So the most important nutrients which are metabolized in livers are your carbohydrate, proteins, and lipids. So your glycogen storage, neoglucogenesis, along with that protein synthesis and lipid formulation happens in the liver. Along with that, storage of trace elements like iron, copper, your vitamins, these are the important functions of the liver. So there are more than 25 functions related to nutrition which liver functions. So it is sort of like a factory which runs the body. Now when this liver takes a hit, the liver progresses from healthy liver to fatty deposits, leading to fatty liver, leading to hepatic fibrosis, cirrhosis, and ultimately a cancer. So our focus today will be just to see how to optimize our chronic liver patients from the dietary point of view. Now, whenever we talk about nutrition in the liver, the most important factor which we have to focus about is a malnutrition in the cirrhotic patient. So malnutrition is an extremely prevalent phenomena in a cirrhotic patient. It affects around 50 to 90% of the cirrhotic patient, and which often goes unnoticed, especially in the early stages of a chronic liver diseases. And it becomes more apparent as the patient progresses in the liver disease. Now, it has a direct link with the morbidity and mortality. So increase in the child's pug score is directly correlates with a worsening malnutrition, and is associated with a worsened and higher mortality and morbidity in this patient. Along with the malnutrition, the another aspect which is very important, and we generally don't uh, give that much focus about, is a sarcopenia in this patient. So sarcopenia by definition is loss of skeletal muscle and mass and strength, and it is a key component of a frailty in this patient. So it is a surrogate marker of a severe malnutrition. This means the sarcopenia means actually around loss of more than 26% of a muscle mass. And this is by studies have shown that this is more prevalent in the Asian population. So this may be related to social and cultural issues like diet, physical activities that may explain the higher sarcopenia rates in Indian and Asian population. Indian diet, which is derived of almost 60% of a protein from their cereals, and this relatively low in digestibility and in the quality. So that may explain the increased incidence of sarcopenia in Indian and especially Asian people. When we talk about the factors which can contribute to overall malnutrition and sarcopenia, it is a reduced oral intake. It could be because of anorexia, dysphagia, or unappealing meals because of a low salt intake. Easy satiety due to ascites, which is causing increase in the intra-abdominal pressure. Decrease intake can be intake during the hospitalization for various procedures or because of a GI bleeds. These can contribute to low intake. Then malabsorption is another phenomena. Malabsorption can happen because of a low bile acids. Factors that includes a portosystemic shunting and chronic pancreatitis also may be a factor which is associated with malabsorption in these patients. Altered metabolism can happen because of a shift from a glycogenolysis to gluconeogenesis. As the liver becomes fibrotic, the glycogen storage gets depleted, and the main uh, process which generates a glucose in these patients is your gluconeogenesis. This will happen only with increased proteolysis and decreased protein synthesis. So ultimately, all these processes leads to hypermetabolism in 15 to 34% of the patient. Also, this could be linked to sympathetic hyperactivity and inflammation because of a disease process itself. So ultimately, when we talk about malnutrition, we need to think about how we are going to screen for malnutrition in this patient. The first question we need to ask is who all need to be screened in a chronic liver patient. So all patients with advanced chronic liver disease, especially those with a decompensated cirrhosis, need to be screened. The malnutrition risk should be assessed regularly at least every 1 to 6 months for the outpatient basis and at the time of admission for inpatient basis. The various screening tools which can be available are easiest which can be used is your body mass index. A body BMI of less than 18.5 signals a high risk for a malnutrition and also sarcopenia. There are various other simple tools which are available. The easiest one to do is a Royal Free Hospital Nutrition Prioritizing tool, which correlates with the disease severity and can be easily done in a very short time at the bedside. The other key components which can be used to assess the detailed nutritional assessment is a muscle mass evaluation by CT scan, mid-arm circumference, tricep skin folds. Whenever we are doing a CT scan in these patients, we need to make sure that we are assessing for a muscle mass also. The additional tools which can be used at the bedside are your hand grip strength, which is a very inexpensive, predicts malnutrition and without any complications. DEXA scans and bioimpedance can be used to detect the overall body composition. Especially your DEXA can be helpful in predicting your liver related bone osteoporosis and osteodystrophies. The another simple tool which can be used is a global assessment tools like a subjective global assessment, and apart from that a Royal Free Hospital global assessment can be used to assess the nutritional status in these patients. So this is a simple chart which actually denotes how we go about. So whenever any chronic liver patient, especially in decompensation, comes to you, you calculate their Child-Pugh score. If they are in Child-Pugh C, then they are at a high risk. Then you assess them for a sarcopenia and detailed nutritional assessment. And based on your finding, then you treat their malnutrition. If they are in Child-Pugh A, then you assess whether they are fluid retained or not. You assess their BMI, and then based on the BMI, you screen for a nutrition utilizing various screening tools, which may predict the risk of a patient's malnutrition. Once you know that the patients are generally almost 50 to 90% of these patients are malnourished. So you need to really look into how you are going to feed them. the most important components are macro components, which you are looking for is energies and protein requirements. So cirrhosis is a state of accelerated starvation, which causes a rapid post-absorptive physiology and metabolic switch from a primary fuel from a glucose to the fatty acids. So which leads to very, very rapid uh, conversion and protein destruction, leading to amino acids which are used as a source of a gluconeogenesis. So this is a basic pathophysiology in the cirrhotic patients, where it is a hypermetabolic state which causes muscles to be destroyed and used as a fuel source. So total energy expenditure is generally compromise your resting energy expenditure plus food associated thermogenesis and a energy expenditure related to physical activities. In a cirrhotic patients, your physical activity is generally very, very less, especially if they are in an advanced stage of a chronic liver disease. So whenever you are talking about a total energy expenditure in these patients, you are mainly talking about just a resting energy expenditure. This is again a hypermetabolic stage where your resting energy expenditure is definitely higher than your normal patients. So you generally target a energy requirement of around 28 to 37.5 kilocalories per kg per body weight per day. In advanced cirrhotic patients, the resting energy expenditure can be predicted using a various predictive equations, but they may be erroneous. So the most best way to assess the resting energy expenditure is indirect calorimetry, but that may or may not be actually feasible in all the setups. The approach to the most nutritional intervention is to supply at least 35 kilocalories per kg body weight per day of energy. Use actual body weight after correction for ascites, or try to use a dry weight. Achieve try to achieve the energy intake primarily by oral dietary intake. If patient is not able to take oral adequately, then think about a enteral nutrition in the form of a nasogastric tube or nasojejunal tube. Also, think about frequent feedings to prevent accelerated starvation and related proteinulysis. The another strategies which have been actually been helpful is giving frequent meals, giving a midnight snacks to these patients to prevent a very long prolonged starvation happening at the night time, and also giving a high protein diet in the breakfast. Along with the energies, the protein intake is to be maintained. So the aim of the protein intake is to maintain the nitrogen balance. The usual recommendation is to try to match around 1.2 to 1.5 grams per kg of a protein per day. In alcoholic cirrhotic, you try to maintain it at around 0.5 grams per kg. In cirrhotic, if they are able to utilize it, then you try to bump it to 1.8 grams per kg of the proteins. Now, there are few strategies which can be used to increase the to decrease the load of a malnutrition and increase the muscle mass. The strategies which can be used are a dietary manipulation or increased physical activities and exercises, some hormone replacement therapies, ammonia lowering strategies, or targeting the underlying liver diseases. So whenever you are talking about nutritional supplementation to increase the muscle mass, you provide adequate calories and protein intake, which may be difficult in advanced cirrhotic. In this scenario, you may have to think about supplementing their oral intake with either enteral form, or in a very, very rare scenario with partial parenteral nutrition. Also, oral nutrition can be supplemented with the branch chain amino acids, which has been shown to improve the muscle strengthening and muscle mass gain, and short-term enteral and parenteral nutrition if your oral intake is inadequate. while we are talking about the exercise and the physical activity, the increased physical activity and exercises will lead to anabolic stimulation, which improves the muscle mass and the function. There are endurance exercises or aerobic exercises which improves your skeletal muscle functional capacity, while there are resistance exercises which increases your muscle mass. So whenever we are talking about a muscle mass gain and treatment for a sarcopenia, we have to subject this patient to both the kinds of exercises, not just the strengthening or endurance exercises, but the resistance exercises also, which will increase not even just the muscle mass, but the functional capacity of the muscle also. The other strategies are hormonal replacement therapies, which can be utilization of growth hormones or testosterone. But there have not been any substantial data which provides the basis for the hormonal replacement therapies. There have been very sporadic case reports which have shown the benefits of hormonal replacement therapy in these scenarios. Also, the long-term ammonia lowering strategies can be used to increase the muscle mass. Hyperammonemia is a result of a impaired protein synthesis and increased autophagy. So, as you lower the ammonia, the muscle destruction will come down and gradually patient will start building the muscle mass. Also, the important pathophysiology for your cirrhotic patient is your NASH cirrhosis. Now, NASH is mainly seen in the obese patients. So, obesity is present in around 20 to 30% of compensated cirrhotic patients. So, there have been studies which have uh, shown that there is a historical progression of decompensation, which has been increased if your body mass index is elevated. So there have been strategies which have shown that if you decrease your weight by around 5 to 10% from your baseline, then it is associated with reduced rate of disease progression, and it is uh, can be achieved with moderate caloric restriction and adequate protein intake. Along with the nutritional strategies, along with your macronutrients, micronutrients are also equally important. The liver is the most important factory or a storage site which stores your macronutrients. So the guideline says that in the cirrhotic patients, you administer micronutrients and vitamins to treat confirmed or clinically suspected deficiencies. The commonly deficient site is your vitamin D levels. So you assess for vitamin D in cirrhotic patients. If there is a deficiency, then you supplement it. The level which is requires supplementation is vitamin D level less than 20 nanogram per ml. And your target is to reach your vitamin D level of more than 30 nanogram per ml. Also, these patients, you will have to supplement them with the other macronutrients such as zinc, copper. Along with that, the another vitamin which needs to be supplementation is your vitamin K. So in a chronically depleted patients, your liver is the one which produces your coagulation factors, which are dependent on a vitamin K to function properly. So somebody who comes to you with a decompensated liver cirrhosis and you suspect them to have a vitamin K deficiency, you generally tend to replenish them from the vitamin K point of view also. There are few strategies which can be used to treat and optimize the nutrition in the patients with the hepatic encephalopathy. So hepatic encephalopathy occurs more frequently in a malnourished patient with a cirrhosis, and there is an inverse relationship between the muscle mass and the blood ammonia levels. So generally, the strategy which can be used to reduce the ammonia production and encephalopathy is you provide them with the adequate energy and adequate proteins. There are few strategies which have been suggested that you tend to provide the proteins in the form of a more of a vegetable proteins rather than a meat or a red meat proteins. Also avoids a long period of fasting. You split their calories and protein intake into small frequent meals like a breakfast and a late evening snacks. Also, there has been historically there has been a thought that ammonia production is a secondary to metabolism of protein. So there have been a thought process of a restricting proteins, especially in a severely hyperammonemic patients where you are not able to control the ammonia. But a protein restriction has not been shown to be better in terms of a overall morbidity and overall reduction in ammonia. In fact, protein restriction is considered detrimental because it will ultimately lead to further muscle wasting, and muscles are the another source which actually metabolize your ammonia. So the proteins which can be used is your dairy or vegetable based proteins. So the Cochrane study, which was done meta-analysis, which had included 16 randomized clinical trials, compared oral or intravenous branch change amino acid supplementation versus the controlled intervention in almost 827 patients, which shows that oral branch chain amino acid had a positive impact on a reduction of a hepatic encephalopathy, but however it was not associated with actual increase or betterment in their patient's mortality or quality of life or a nutritional status. So the supplementation of branch chain amino acid may be a bit controversial subject. The another thought process in this is probably the better results or reduction in hepatic encephalopathy in these patients was found in a vegetable proteins with a branched chain amino acid, because the vegetable diet is high in their fiber content, which was actually the reason which actually benefited the patients. So the fibers, which were both prebiotic as well as laxative properties, were actually responsible for reduction in hepatic encephalopathy rather than just the branched chain amino acid or a vegetable source of a protein. The another important problem which we face in a cirrhotic patients is a bone diseases. So hepatic osteodystrophy and osteoporosis and osteomalacia is a common factor. It is a multifactorial etiology: nutritional, hormonal, metabolic, genetic, as well as inflammatory factors, which contributes to decreased bone formation and leads to osteoporosis. Almost 30% of the patients of a chronic cirrhosis and chronic liver disease will have a osteoporosis. So the investigation is, whenever you're suspecting a patients with a chronic cirrhosis, you diagnose them with a DEXA scan or a lateral hip X-ray, and laboratory investigation include your calcium and vitamin D metabolism. If your T score is more than 1.5, then repeat DEXA scan every 2 to 3 months. If it is between 1.5 to 2, repeat every 1 to 2 years. Or if it is less than 2.5, you repeat every 1 year. If you are diagnosing the patient with a deficiency or osteoporosis, you need to supplement them with a calcium of around 1000 to 1.5 grams of a calcium per day, and vitamin D supplementation of around 400 to 800 international units per day to preserve their normal levels. So I think Dr. Arindam, hello.
Yes, please.
Yeah, so I will stop at this point, sir, and I think we can go on to the panel, because then we can just go on to the specific scenarios and the panel discussions.
Fair enough. I think you have given us a very good head start, and you have explained most of the things. And now let me invite the panelists. I will start with you, you being the integral part of it. And so Dr. Jitendra Chaudhary is our first panelist. And the panel cannot be complete without the ISPEN president, the present president, Dr. Sanjeet Sashidharan, who is also the director of critical care, the SL Raheja Hospital, Mumbai. So he would be our second, two intensivist, the second panelist or the prime panelist. So both the ISPEN president, Honorable ISPEN president, and Dr. Jitendra Chaudhary, representing critical care. I would invite Dr. Ellen Kande, who is the senior clinical nutritionist as well as the head of the dietetics department of Sir H.N. Reliance Foundation Hospital, who will give us a viewpoint of the nutritionist or the dietitian so that we can understand proper nuances of it. And we have Dr. Mridul Dharod, who is the super specialist in hepatology, clinical hepatology, and a senior consultant. Again, a little biasness towards H.N. Reliance Foundation Hospital. So Mridul is also a colleague and who takes care of all our critical care hepatology and liver transplantation, medical component of the liver transplantation patient. And am I missing anyone else, Jitu? No, I
No,
think. And obviously, Dr. Jairam and Dr. Chandrima is the default part of the day. So we have had a very nice session. So we'll quickly come to an end. We learned about the assessment of malnutrition, sarcopenia, and all others. So my question, I will start with Dr. Eileen, is that what is the practicability and applicability of the assessment segment? How frequently you do it, and how important it would be? Ma'am, you have to unmute. Yeah.
Yes. Yes, thank you, Dr. Arindam, and the entire panel here today. Very excellent talk given by Dr. Jitendra, and he almost covered every nutritional aspect that was required. In fact, Dr. Arindam, when we started assessment for patients with liver diseases, we initially started with the SGA, and eventually, when the patients were getting admitted in the IP area, we used to previously do the NRS 2002, which we currently follow for our ICU patients. However, after going through a lot of theory and understanding the guidelines that were given by various bodies, we have shifted our assessment tools from these to the Royal Hospital nutritional prioritizing tool, that is the RFH NPT. We also created a tool that was integrating not only nutritional aspects but also physical aspects, as well as the other aspects of body composition analysis and the muscle mass, etc., to come out with a comprehensive assessment rather than looking at it only from a single nutritional tool point of view. That's what we did. We sat with the liver team, and it took some time by the time we could comprehend the entire thing, because it involved different teams. It involved the physiotherapist, it involves the nursing, and it involves the dietitian. So it is a very long process of doing an assessment, and we realized that doing a thorough assessment was the first step to the treatment.
Recording in progress.
Dr. Mridul, do you include your assessment report? Particularly, you see a lot of patients who are repeatedly coming to your OPD or your admission in an IP. So
Yeah.
do you include and monitor the nutritional assessment routinely in your patient records?
Yes, so we in our OPD area we have this body impedance assessment. So definitely, whenever a new patient of cirrhosis comes to our OPD, once we have done the overall assessment regarding the cirrhosis and its complication, and then depending upon whether the patient is in what kind of a cirrhosis advanced stages, whether child's class A, B, or C, we tend to advise our patients for a physiotherapy as well as a nutritional assessment. And definitely we encourage them to be involved in the various programs so that they can be nutritionally built up, especially from the physiotherapy aspect. And whenever then the patient is coming for a frequent follow-up, we do a BI assessment, body impedance, and see how the muscle mass is going, how the fat is behaving. Definitely, sometimes the ascites or overflow, the fluid status can make some sort of a confounding this thing. But BI assessment is freely available, and that is the common thing that most of the time we do in our OPDs.
Dr. Sanjit, I hope I can see Sanjit.
Sir, Sanjit sir is joining.
Ajay is joining back. Okay, I will come back to
Joining
NA.
back.
Regarding I think Jitendra, you had given us a daily target of protein and calorie, right? And you have very clearly, uh, I think you have very clearly said that there should not be the restriction, any protein restriction on that, right? Can you re-emphasize that
Yes.
point? That we should not be afraid of hepatic encephalopathy and restrict protein. Rather, that can be detrimental to the patient itself.
So, right. So generally, we don't like to give them a protein restriction. We generally will at least target around 1.2 to 1.5 grams of a protein per day. That is our minimum requirement because these patients are already sarcopenic, they're malnourished. In this situation, a further restriction will hamper our further increase our muscle loss. So we generally tend to be very avoid restricting proteins around minimum 1.2 to 1.5 grams of protein we emphasize on. And I think that we really judiciously follow with the dietitian's daily round. We do our daily calculations and make sure that patient is really getting that amount.
Mridul, do you agree with this? You do not have
Yes,
any issue. Rather, you would be
completely.
encouraging to have more proteins, right?
Yes, we completely agree. So even on the OPD basis, where we commonly prescribe most of the protein supplements, protein bars for patients, and especially in a sick cirrhotic when he's admitted in the ICU, whether as a ACLF or a cirrhosis with a complication, where in fact the calorie and the protein requirement is on a higher side. So most of the times we would be recommending a higher protein intake and a high calorie intake. The only rare circumstances where probably we have advised the protein restriction has been a refractory encephalopathy where we have tried everything else and this patient is not getting better. There are no shunts available. The ammonia is still very high, and we have ruled out urea cycle defect. Probably is the time when we have advised for a protein restriction. Otherwise, now we advise high protein diet because the cirrhotics need high protein to build up a normal protein.
What about a refractory? You said. What about a patient with the tips? Would there be any
The patient with
specific?
tips. No, so tips usually we would advise. So there are
Because we
two
know that tips predisposes towards a little bit of encephalopathy. Whether
Yeah, so that's what. If the tips has been done for ascites or refractory hydrothorax, we would have selected that patient where the MELD score is not very high. So here the chances of encephalopathy are as such, we have selected a patient where the chances of encephalopathy are less. So here again, there is no restriction as such advisable. A patient who has come with a bleed, a GI bleed, where the MELD is really high, and if we have done sort of a rescue tip, we don't know how it's going to behave subsequently. But
right.
to begin with, there will be no protein restriction advice.
Okay. So, but it would be a dynamic situation, and if there is an refractoriness or recurrent encephalopathy, maybe then
So
we can
no, so
discuss and
here
rethink about it.
still the treatment would be to decrease the size of tip stent. Generally, we advise like a 8 millimeter tip stent. So we would rather downgrade to a 6 millimeter stent rather than advising for a protein restriction.
Okay, fair enough. So I think we got a
I
very
think
clear answer this. Yes, Jitendra.
I think in the last 1 year, Mrudul, we have only restricted for one patient the
One patient,
proteins.
one
Yeah,
yes patient. That's
because
what.
we
One
were really
patient.
struggling to control the ammonia despite
Yeah.
being on a CRRT and plex also.
Yes.
That was the only
So
patient where we had
that should be our last resort.
Last
Okay,
exactly,
resort.
Dr.
exactly.
Sanjit is back. I will come to you if, whenever you're free. But before that, Dr. Eileen, we all know we are good in prescribing. We doctors are right, but you must have seen that the deliverance at times are obvious always suboptimal. So, what is your take on this? What we call very specific protein calorie debt, particularly in this sick group of patients of critical care hepatology.
So, Dr. Arindam, actually, the challenge is to feed these patients because there are reasons why their appetite may be low. They may not be feeling like eating, they are nauseous or they have ascites. So in those situations, we do have challenge in feeding them. However, if there's a patient who is in the OPD and we need to feed them, we definitely, what I generally do is I take a very good dietary history and see what they are currently eating. And as we know, most of the diets here, in India are carbohydrate-based diets. So it's very difficult for us to actually look at to find proteins in their current diet, even if they have a good appetite, even if their appetite is normal and they do not have any other compensatory issues. So the challenge here is to reach that protein target if it is an oral diet. When you divide their day into breakfast, lunch, evening snack, and dinner, say 5 meals or 6 meals per day, and if I have to reach a protein target of 60 to 80 grams, as we say that we need about 1.2 to 1.5 grams of protein. So even if I want to reach 60 to 80 grams proteins, it means that I have to deliver and I have to prescribe them per meal at least 20 grams of proteins. Now, patients don't understand how 20 grams of proteins look in the first place. So I have to do that kind of measurement and show them how much of one bowl of dal would be in terms of protein. So if I have to tell them 7 grams of proteins in the dal, or one bowl of curds, how much protein that. So when I show them the amount, they really get scared and they say, no, I'm not used to eating so much of food. I can't eat so much of food. Because at the most they will eat one small bowl of poha or a small bowl of upma and they are full. So these are the patients, these are the actual on the ground challenges that we are having to feed them. Secondly, giving 20 grams of protein per meal to reach a 60 to 80 grams is very, very difficult in a patient who's already having other issues of consuming food. Besides them being not the normal healthy individuals, even when they were healthy, they did not eat so much. So to convince and to educate the family how to feed them becomes a challenge here.
And that's a practical situation, right? So we give you the targets, but achieving that target and also maintaining that, particularly the patients who are on a OPD basis, at times could be, or even in the acute situation where there are so much of interference because of the procedures, the the acuity of the situations, vasopressors, and all others, that becomes a thing. Sanjit, you are a very few of the intensivists who are using indirect calorimetry in the country itself. So, what is the specific role and how it benefits you in this particular subset of patients of critical care
So,
hepatology?
so I'll tell you, most of the guidelines would actually say that you use 30 to 35 kilocalories per kilogram, and even Dr. Jitendra has alluded in his PPT that it has to be 30 to 35 kilocalorie per kilogram. That is based on the predicted body weight or the ideal body. However, here the weight is the biggest problem here. So using that is kind of impossible to do. You cannot do that because most of these patients have ascites, they are not pretty okay. You can't really have an average weight over here, and that is why IC becomes very important. And importantly, what is important here is if the person is going to build his protein, build his glycogen, build his overall nutritional status, he will require close to 150% of his resting energy expenditure. So when you're looking at 150% of the resting energy expenditure, you'll be surprised that people may require anywhere between 1,000 to 1,500 to 4,000 kilocalories. This is the amount that will be required. So unless you measure, I don't think you can by any way understand how much calories to give in the first place. So that's the first challenge. The second challenge over here is that, remember this, the peak VO2. The peak VO2 of these patients are somewhere around 17.4 ml per kilogram per hour, which means what, which means they are actually having a sedentary lifestyle. When they're having a sedentary lifestyle, they are looking at an elderly 80-year-old is the peak flow. What I'm talking about, 17.4. When we reach 35, we all are at 35. We are at 35 to 40. So this is 17.5 4 milli-ml per kilogram per hour. So all the more reason that it becomes extremely difficult to how to feed these patients. Okay, and importantly, what we must also understand is, as Dr. Jitendra alluded in his topic very well, that vegetable protein seems to be a very good means of giving those proteins. Remember this, vegetable proteins per se cannot meet that protein requirements that we have. 1.5 gram per kilogram if you think about it. So that way it becomes an extremely difficult, cumbersome challenge that comes in over here. And that's why I completely mirror what Aline is saying. Aline says very clearly that it is impossible to actually manage them. Well, it is very difficult to manage them is the answer. And importantly, when you asked me the first question, I'd like to allude to the first question also, Arindam, when you talked about screening these patients out, if it's okay with you. Can I do it?
Right, please.
So I feel this very important, very important thing is to screen out these patients early. Because if you start screening them when they come to the hospital, when they are admitted into the hospital intensive care, you've possibly lost everything. This is the point over here. So it has to
Okay.
be screened at the first admission to the OPD. If they come to the OPD and these people are actually being seen by a gastroenterologist hepatologist, they will be doing a CT scan. There is no doubt about it. And if they're going to do a CT scan, it's very important to look at the L3 muscle mass. And that has got very clear denomination to say what is the Asian working group saying that, those are the ones who have low, somewhere around 39 in females and 58 males are going to be malnourished. BI is not a good tool. Let me be clear about this. And why is it not a good tool? Many of these patients have got ascites. And remember this, ascites is the enemy of a BI. It will overestimate the skeletal muscle mass. That's why the bioelectrical impedance analysis, if it has to be done, it has to be done only after a paracentesis in patients who've got ascites. So BI is not a great tool to be used in especially in patients with ascites and liver cell failure. MRI can be used. MRI also sometimes is done. And MRCP is done. The same value, psoas muscle thickness divided by height in meter square. This can be used for patients who are being screened. But we must not forget very simple things like hand grip dynamometer. A hand grip dynamometer can actually give us a better estimate of malnutrition screening as compared to any of these tools that are there. And remember this, we've got the Chandigarh SAR-Cube study, which has actually told us how much amount of hand grip a person requires. That gives you a clear screening. And importantly, the most important concept that is coming out in the last 4 or 5 odd years is something called as liver frailty index. Now, the liver frailty index can be done in the OPD. A liver frailty index is done by actually doing a hand grip, a chair stand, and a balance test. And this is a very important score. Liver frailty index more than 4.5 is one of the reasons where you will think of screening out these patients for malnourishment. So I think it has to be comprehensive. You can't use just one tool. It has to be comprehensive, including a DEXA, as the Jitendra said, because the DEXA will give you the BMD, which is responsible for hepatic osteodystrophy. So in short, a screening is very, very important at the OPD. This is what I would put it as, at the OPD, so that we can have good cognitive improvement, so that we can have good physical rehabilitation, so that we can have functional mobility. Once the patient comes into the hospital and gets admitted for a cause, we've lost most of the things, I feel.
I would request both you as a president of ISPEN and also Mridul is here. He is into a lot of hepatology forum. In fact, he works with Dr. Akash Shukla. You guys are doing so much of liver transplantation and work over there. I think we should have a collaborative effort to come up with a very simplistic, realistic, and applicable screening process for our patients, so that I really completely and very strongly agree with Sanjit, your word, that by that time they are into an ICU, and if they are malnourished at that point of time, we are definitely in backfoot. We have almost lost that game on that part. So that is a very important take-home message on that. So I would now ask very direct questions, right? If you have remember that in forensic we used to call this leading questions, right? So yes, no, or very one sort of answer. So, and I would ask a specific panelist to answer on that. Dr. Eileen, animal protein or a plant or vegetable protein?
It's
Which
not
one?
like that. It can't be either or. It has to be a balance, right?
Now,
So,
the balance is tilted towards
no,
home
so
because also the yes, yes, please.
no, so given a choice, when you start and you look at branch chain amino acids, that's when I will go in for the plant-based coupled with a little bit of animal based. So if I even want to give an egg to the patient, and I want to give the other because I need to meet my targets. I cannot do that only with a plant-based. Yes, even in a vegetarian patient, I
And
still
how do you convince that? That was my question also. How do you convince a strict or strictly vegetarian patients or a Jain patient to have that one? Yeah.
No. So a strict vegetarian patients and a Jain patients, we do respect their sentiments and their religion, and we within what they already consume. So there are only two sources. One is the vegetable protein, and the other one is the dairy protein. So we do a combination of a low fat dairy and a vegetable protein in order to reach the target protein requirement.
Mridul, importance of branch chain amino acids. How do you emphasize that
Yeah, so branch
to our
amino
viewers?
acids, leucine isoleucine valine very important, especially patients like who have this advanced cirrhosis and whether hyperammonemia or encephalopathy part is there. So anyone who is a child's B or child's C cirrhosis would require a branched amino acid as a supplementation. Just to add to what Dr. Ellen Candy says, so this veg protein versus animal protein, this debate was there in the 1950s, where they initially thought the veg protein associated with the fiber would help in the bowel movement and cause a gas and the bowel pH to be on the lower side, and that's why it will be better in terms of encephalopathy. But now, since we have been using rifaximin, we have been using lactulose to decrease the pH of the intestine. Definitely, only vegetable protein is not necessary. So, if someone is willing to take animal protein, fair enough, we can give it. It's no restriction on the animal protein part. And coming back to what you said, just what you asked me about.
Branch
BC
aminoas.
Yeah, branch
BCAA.
amino acids. So most of the nowadays the powder supplements, the protein powder supplements that we have been prescribing to our patients have a lot of branch and amino acids because we have seen that they make a real difference in the encephalopathy. Those who have especially like the minimal encephalopathy, the grade 1 HE, it is making a lot of difference. So everyone who is child's B and C, we would advise them, especially all those patients who also have a sarcopenia. So it is recommended.
Jitendra, quickly, we are running out of time. Vitamins and trace elements
So
in your
we generally
prescription.
we generally supplement them whenever they come to ICU. We generally supplement them with a high dose of optineuron, which is a combination of vitamin plus uh, there is a trace element supplement which comes as a Bond 7 or Otski or whatever the brand name you can use. So you generally supplement with all the cirrhotics or chronic liver disease patients with these supplements, and along with that zinc.
Yes.
Okay. Uh, at point time, I think Swapnil Khadke has put up a question that at times it is very difficult to feed and there is always a big gap in between. So at one point of time, Sanjeet, we should consider at least if, even if we don't start, or at least we should consider a scope of parenteral nutrition and what exactly the scope and whether there is a role of what we call nowadays it's quite a bit of a fad is that the supplemental parenteral nutrition.
Yeah, so there is a fantastic role of a home parental nutrition. I would not say intensive care unit because intensive care is acute catabolic response. Nothing really works per se. But if you look at ward and home, yeah, home parental nutrition is something that will make a lot of difference because of the fact that you would give nighttime nutrition. So nighttime nutrition, that is the time when the liver is really down, glycogenic stores are going down, fatty oxidation is at its peak. So at that time, we normally want to give home PN to these patients who are at home at a very low rate. It's not going to be a high rate because we know parenteral nutrition for long term can cause liver steatosis, and that steatosis can be alarmingly dangerous. So there is a definite role of PN, but remember this: PN becomes alarmingly dangerous if you assume body weight. It's very important for us to understand this because if you look at resting energy expectation via indirect calorimetry, you might be anywhere from 1,000 to 4,000. So if it's 1,000 and you then feed them 2,000, you are going to land up with problems with respect to liver and refeeding syndrome because these are essentially malnourished patients. So lesser feeding is always and always better. And on that practical note, parenteral nutrition, especially with omega-3 fatty acids or fish oils, are going to be the way to be done. Because if you were to give omega fatty acids, there is going to be a release of antioxidants, tocopherols. This is going to cause reduction in hepatic steatosis. It will reduce the nuclear factor kappa beta, TNF alpha, and it will benefit these particular patients. This is why in pediatrics, when you have extreme cases of glycogen storage diseases and things like that, fish oil is known to have got benefit. And that's why last 4 or 5 years, we've had a combination of fish oil with soybean, with olive, with MCTs in our parental nutrition. So fish oil would be the way to go as time goes. There are no head-to-head comparison with fish oil and just intralipids. Once it comes in, you will be certain that it's going to be fish oils are going to be the way it's done because it's logically and physiologically right.
I think we have got a very elaborate answer on that. In fact, by my next question would be to both Jitu and Mridul. You take 30 seconds each to give us an idea about that whenever we are choosing parenteral nutrition, there is always a thought process that we should restrict lipids, in particularly this liver patients, right? Because of the fear of hepatic steatosis. So do you conform to it, or it is unfounded? The fear is unfounded. Both of you. Jitu, you can start, then I will come to Midhu. You are muted. You are muted. Please unmute.
I would not really like to restrict them to just non-lipid based proteins. As Dr. Sanjit rightly said, probably my go-to nutrition will be SMOF everywhere. That is omega 3 fatty acid and all that.
Best of. Yeah, Mridul, anything to be worried
I
of,
agree. No, I
even in
agree.
the fulminant hepatic failure or ACLF?
No, I agree. Matlab, we should not ideally be restricting fat. In fact, if we are restricting fat, matlab, it's illogical. We should not be restricting. Most of these patients are going to be deficient in all sorts of calories. So fats are an important person. We would like to do.
Particularly if you have to achieve the calorie target
Yes,
itself.
yes,
Dr.
yes,
Helene
yes.
and Dr. Sanjit, one line. Yes or no? Would you supplemental
So it
in
is
a
it is a
parenteral gap?
myth. It is a myth that patient with cirrhosis should not get fat. It is a complete myth.
Yes.
Remember this, the energy extraction often shifts to fatty acid oxidation from glucose. And the ready
Yes,
availability of
yes,
these fatty acids
absolutely.
may spare muscle breakdown. So fats should be given. If you have a problem, restrict the fat or change the way the fat is given.
I
Either
think this
intrathecal
has
or
to be a very strong message
So,
towards it, that rather it could be detrimental. Yes, ma'am.
so we give about 30 to 40% of the energy does come from fat. We look at the quality of the fat and the type of fat that we give. So I often get questions from patients that can I eat cheese? Where, cheese is considered as protein, where actually it is sodium and fat combination. So there is a lot of misconcept of what fat actually is. So there a lot of education has to go in as to the type of fat to be consumed, how much to consume and when to consume. So those kind of foods have to be put in between the meals. Of course, if it's on in the ICU, we also look at fats from the supplementary feeding that we are giving.
The other thing I would I'm now skirting towards a little bit of controversy, because we are finishing almost finishing the time itself. Uh, Many a times it was an a that to increase the level of albumin we have given, and anyway these patients are very frequently receiving albumin. Mridul, do you think albumin can be sort of contributing towards increment in the muscle mass or the protein buildup, or
Not really.
it's not?
Not really. So the only official or the known indications of albumin infusion should be SVP and HRS, or post tapping the circulatory dysfunction that we get. Otherwise, most of the
PICD.
time, the albumin sometimes in a sick cirrhotic is actually more detrimental, especially those patients with significant pedal edema and all. This albumin, which diffuses out into the subcutaneous tissue, tries to retain more water, and then that fluid is more difficult to mobilized. Plus, the albumin going into the lungs, sometimes these are what we call as a leaky capillaries and all. So, albumin should not be used for each left, right, this thing indication in the ICU. It should be sparingly used. It is definitely not going to build up the muscles. It's a myth. So, just because artificially the albumin level is at 2.2, 2.4, I would not give albumin to increase the protein level or the albumin level. I would rather supplement the proteins and see if the liver is functioning enough. It would try to make the albumin on its own.
I hope you convince your surgeons also like that, the way you did here. Sanjit, do you agree on that part?
Absolutely. Albumin is for the surgeon. Albumin is for the surgeon. Albumin is for the surgeon,
That
nothing
would
more.
be another. The other controversial thing which has been tried, I think, I will ask you, Sanjit, is the growth hormone, the hormone therapy, particularly for a very cachectic malnourished patient, the growth hormone has been used. Any take on this?
Fantastic question. So, if you look at hormonal deliveries, I would really not only put hormones over there, I'll put, say, others. In the others, growth hormone is something that definitely makes a difference when it comes to muscle mass. It also helps in the release of ghrelin. Now, ghrelin is something that actually causes the appetite to get better. So, it causes the ghrelin to get better. There are very small studies, but there are studies that have actually looked at growth hormone. Another very important hormone is testosterone. Remember this. It is advanced in advanced CLD. It is associated with decreased muscle mass, and giving that testosterone in deficient CLDs will actually improve muscle mass, bone mass, and hemoglobin. It's very important for us to understand testosterone. And another very important element I would say is L-carnitine. So these are three things which will help these particular patients to get better. So I'll put all these three in one basket and tell you these are the three things. If someone has to give different kind of meds, these are the three meds I would give to any of my patients, including anabolic steroids like oxandrolone. Oxandrolone 10 milligrams twice a day will also help in such cases. Yes.
Yes, I think this has been it's very difficult to have a mortality benefit or a very clear benefit on that part, but it's worth trying for anabolic steroids, growth hormone, L-carnitine, and when the situation is really desperate. Particularly, Mridul, I will again come back to you and also Dr. Eileen, to both of you. When you are really thinking of a preoperative optimization of a patient, particularly who is going to undergo a liver transplantation. So your take on this. I will start with the lady and on that. So how do you really optimize preoperatively?
So definitely, as I said in the beginning of my this thing, that we do an assessment, not only a nutritional assessment, we do a physical assessment as well as the appetite of the patient. Now here we also look at various other aspects such as BIA and everything else. Besides that, I think explaining to the patient and the family the importance of food in order to be prepared for the surgery is the most important part there. And that requires a very close connect between the dietitian, the team of doctors, as well as the physiotherapist. All three together, because only one person cannot be able to manage this entire scenario.
Mridul, how much weightage do you give for nutritional optimization in
No, I
your
give
transplant
such a
recipient?
lot of weight. In fact, if you see, if there are 10 patients in my OPD with cirrhosis, and if I advise them to visit a physiotherapist or a nutritionist, hardly for 2 or 3 out of them will go. But as a part of a transplant, since I need a nutritionist, what we call as a clearance, a physiotherapist clearance, I make to sure that everyone goes to a nutritionist. I make sure goes to a physiotherapist so that they evaluated properly. And definitely, if it's a living donor transplant, we have some time. We would try to optimize them as much as possible. In fact, we have designed some physiotherapy programs. We try to engage more time with the nutritionist and the physiotherapist so that they are built up peri-transplant. Because if they are sarcopenic, if they are frail during the transplant, then the recovery is going to be extremely difficult. In fact, I give numbers to the patient. If you are good with your muscle mass, if your chance of recovery is 90%, with frailty, the chances are less than 70%. So this itself gives them a good motivation to get engaged in this kind of programs.
In fact, Dr. Arunam, we have, when the liver team came in, we did not have a PMD, what we release. Now we have created a PMD, which is a cumulative one, which gets released for the patient. We don't work like in silos, like, each team doing
Right,
its own
right,
PMD.
right.
We have created one PMD, which gets released, and then that entire patient's profile is seen in one page.
Fair enough. Jitu, quickly, Chandrima is pushing me. The time is almost over. Quickly say that, is there anything specific precautions or intervention that you do in a peri-transplant period regarding nutrition?
Peri-transplant, definitely, as preoperatively, we try to optimize them as much as we can, especially if it is a live related donor. In fact, we have been sort of like some patients we have really pushed on a home-based rice tube feedings also, nasogastric tube feedings also, if their oral intake has not been adequate. And after proper optimization only, they are generally taken for transplantation. Post-operative period also, we like to start them feeding as early as we can. So probably in first 24 hours, the feeding starts, nasogastric feeding starts. Hello. Yeah.
Yes.
Mm.
Jitu, your signal is dwindling. Yeah.
Yeah.
So last question before we ask a closing remark from all the panelists. It goes to both Mridul and Dr. Helene. Is there anything that we should be of concern regarding the drug food interaction in a transplant recipient, particularly because a lot of immunologic medications are being used? Anything that we should be aware of?
Not particularly with any medication as such, because here we don't really find warfarin and all those things being used. So we don't look at any drug nutrient interaction where liver is concerned.
Mridul, anything? A drug or a drug
No
food interaction?
interaction per se, just that one thing that I noticed and when I spoke to with couple of patients, usually we know as a part of immunosuppression, we commonly use tacrolimus. And the usual recommendation is that you take tacrolimus at 8 o'clock and half an hour later you start having a breakfast. So some patients do complain that they feel bloated or they do not feel like eating. So here we have asked them, okay, take the tacrolimus after the breakfast. The food should not suffer just because it has been instructed it should be taken after the drug. You can always take the drug after the breakfast and so that your food intake should be proper. So that is the only thing. Otherwise, no interaction per se.
Fantastic. So can we have a closing remark from all of you? I would start with Dr. Jitu and
So
one line.
I think,
You
yeah.
summarize.
So diet is definitely important for all our critically patient, but more so for our liver patient. So we are very, very uh, vigilant about their dietary nutrition and requirements.
Okay, Dr. Eileen.
First of all, I'm glad that we're talking about nutrition and diet. That is the most important thing. Secondly, is I think we also should, understand that giving bulk for the patient becomes very, very challenging, and we should look at foods that where we do concentrate, give them smaller amounts and more calorie and nutrients. That is the challenge which we face, and we just need the support from all the doctors.
Okay, so we would be there for you, ma'am. Don't worry.
Thank you.
Dr. Mridul.
Yeah, so my way of addressing, we should not feel that we know everything that we can do from the nutrition aspect of the patient. We should involve the nutritionist or the dietitian more often so that they can guide us and the patients in how to build up the nutrition. Sometimes, the doctors do not refer them and they just say, okay, take this much protein, but we are not able to integrate that into the normal diet and everything, which a dietitian or nutritionist are better able to do.
And
Dr.
there are a lot of myths with the patient, and those myths we need to be on the same page.
Yes.
Okay, so we will have more webinars and we will invite a lot of patients also at times, right? Patient advocacy and others. Sanjeet, you will close the day, you being the president, and you get 3 lines. Privilege of a president.
So thank you, Arindam, for this. And I must tell you, Arindam, you moderated this to the core perfectly. And I must say, Arindam, these questions were framed so beautifully that these are the questions that we normally want to ask most of our people and understand also. Fantastic fare from your side. My 3 points would be: 1, early screening and implementation of a nutrition protocol. That would be my first thing. Early screening and implementation of a nutrition protocol is the first thing. The second thing is multidisciplinary care throughout the unit. Multidisciplinary, as Eileen said, that nutritionists should be there. As Jitendra said, that there has to be a combined intensive care gastroenterology follow-up. As Mridul said, that there has to be a physiotherapist in place, which will actually have the form, intensity, type, and the way we do exercise. That multidisciplinary care should be there throughout, start to end. And importantly, even after the patient goes home after a transplant, remember these patients had a negative nitrogen balance for 5 years to 6 years. And that is the reason that prolonged nutritional support is something that we would probably look. So all these patients should come back to the same multidisciplinary care, and then only we can affect any kind of improvement in functional status. Thank you.
Thank you. I think it was my first program with ISPEN itself, and I hope it went well. And I would be happy to contribute in any form in the future programs. So thank you to all the panelists and as well as Dr. Jitendra as a presenter too, both as a panelist and presenter. I now go back to Dr. Jairam, who would be doing the closing session.
Thank you, sir. Before giving vote of thanks, I would like to invite Dr. Kapil Borao, sir, from ISPEN Pune branch. He is the organizing secretary of ISPEN Pune, and he is the director intensive care at Sahyadri Super Specialty Hospital, Hadapsar. He will tell us about the upcoming ISPEN Pune National Conference. Over to you, Dr. Borawkar, sir.
Good evening, all of you. First of all, a very interesting session. A lot of things to learn from. It's my pleasure to. Can I have a slide? It's really pleasure to have on behalf of organizing committee of ISPEN Pune for the 19th annual conference of Indian Society of Parental and Enteral Nutrition to be held in Pune. It is on 13th of November and 1st of December, and make sure that through the continuous support from President of the society, we have found a fantastic program, and which includes a lot of thematic sessions, debate, hands-on, profound debates, and workshops, and many interactive sessions, and very disease-specific nutrition topics. And I think it will be a very well worthwhile for everybody to attend these sessions. And that session of 2 days, that is Saturday and Sunday, we will start with boot camp on Saturday, and Saturday afternoon will be starting by 3 p.m. And on that Saturday evening, we will have a very surprise gala dinner with one cultural program, which will be rocking program. You all will be, I'm very sure, will be very happy after attending that gala dinner. That much all arrangements are made from Pune branch with the support from center. All the invitations and a detailed program will be sent to you as per the protocol of National ISPEN guidelines. And we are in constantly touch with Sanjeet and with all his support and guidance and local. Dr. Subal Dikshit, he is our organizing chairman, and Dr. Kapil Jirpesar is chairman. And my co-organizing secretary is Dr. Sushma Gurosh. So all of four of us will be very happy to have you here on 30th of November and 1st of December. So looking forward to welcome you all on these 2 days.
Thank
Yeah.
Thank you, Kapil Borawka, sir, for giving us about idea about the ISPEN Pune National Conference. And we are coming with the full of bus. And I am also inviting all the panelists to come for the Pune National Conference. And thank you for Dr. Jitendra, sir, for such an excellent presentation and very informative session. Thank you, Arindar Kar, sir, for moderating this wonderful session. Thank you, Mrudul sir. Thank you, Elaine Candy madam and Sanjit sir for being a expert panelist. I would like to thank ISPEN and Sanjit sir for allowing the ISPEN Mumbai branch to conduct this webinar without any sponsorship. Many more webinars of the ISPEN Mumbai branch will be in the line. Next webinar will be held on 28th of the October, which will be on the nutrition in the burn, and link for this webinar will be shared shortly. With this, we are ending this session. Thank you all for the participant and for attending this session till the end. Thank you.
Thank you very much. Bye-bye.
Yeah. Bye, Sanjit. Thank you.
Bye-bye. Bye-bye. See you. Bye-bye. Thanks. Bye-bye.
Thank you.
Bye.
Bye. Bye.
Even I asked Dr. Prabha as a head of